My name is Silvia Vilarinho, and it's a pleasure to follow Verena's talk. I'll try to focus on the value of genetic testing for late onset of genetic cholestasis and really focus on a case that I think touches on some teaching points. So just as an introduction and putting a lot of what has been said by Verena before, I just want to show in the x-axis a timeline of the milestones in human genetics. So it was around 20 years ago that we found out that our human genome is composed by 20 protein coding genes. And due to that knowledge, there was a lot of advances in industry to actually make sequencing costs go down, as you can see by the drop in the mustard color, by the line that is in mustard color. That really enabled recognition and discovery of many genes associated to liver disease, as depicted by the gray color in this chart. And one, I think, important aspect is that like in the before 2003, only 3 genetic deficiencies that causes cholestatic liver disease have been uncovered, the PFIC1, PFIC2, and PFIC3. In late of the 1920s, also mutations in heterozygosity in ABCB4 had been associated with intrahepatic cholestasis of pregnancy, which you have been hearing quite a bit about that in the previous talk, and you will hear more on my talk. But really was the advances in next-generation sequencing and the understanding of the human genome that has allowed for many more genes to be discovered and associated with genetic cholestatic liver disease. And one could argue that several more or many more will be discovered in years to come. So something that was thought to be very rare and mainly presented in pediatric age, I should mention that all these papers actually pre-next generation sequencing and post-next generation sequencing, the discovery had been in pediatric cohorts, will be more prevalent in our practice. One, because these children will become adults, and the pediatricians are doing an excellent job, and they are doing very well, and we as an adult hepatologist will have to manage them, but also because, as have been shown, these diseases that were previously discovered in pediatric age will be actually also presenting in adult age, and we adult hepatologists have to think about them in order to diagnose them. So the case I'll be discussing today is a patient I have seen a few years back, that she was pregnant for the second time. She was in her early 30s, and she actually was transferred to our hospital because she was having a variceal bleed during her second trimester, which always is an excitement for someone that is on call receiving this patient. In terms of her past medical history, she had her gallbladder removed in her 20s, which you just learned that it's maybe a potentially red flag or should have been putting you thinking about something. And she even had an episode of intrahepatic cholestasis of pregnancy during her first pregnancies. Actually, one of our colleagues had thought about possible genetic disease and has sent genetic testing. And she did okay, and she delivered at 36 weeks a healthy baby. Her family and social history were really non-contributory, so no family history of gallstone disease or cholangiocarcinoma or intrahepatic cholestasis of pregnancy other than her personal history. At that time, the genetic testing was sent, and she was found to have one heterozygous missense variant in ABCB4. This mutation has not been reported associated with disease, but there was a mutation on the same amino acid, the arginine 549, that had been associated with intrahepatic cholestasis of pregnancy in one case report and was read in the ClinVar as of unknown significance because there was not more than one case with intrahepatic cholestasis of pregnancy. She had all the features that normally are associated with ICP. So she had pruritus, elevation of serum bile acid concentrations. It really happened in the late second to early third trimester, and it really rapidly resolved after delivery. So she was seen once after 6 weeks after delivery. It seemed that her AST and ALT were coming down, the serum bile acids were almost normalized, and she never really followed up with an hepatologist. So then she comes back during her second pregnancy with a variceal bleed, as I mentioned to you. At that time, her ultrasound showed an enlarged liver, heterogeneous. There was no focal mass. And she also had a post-delivery MRCP, which actually comment on a possible intrahepatic ductal strictural stenosis. There was this mild intrahepatic delayed ductal dilatation with multiple filling defects. And so there was a moment where PSC was actually entertained, but then she had a follow-up ERCP because of these findings, and she had a completely unremarkable biliary tree, so that was actually excluded. During this time, she also had a liver biopsy and was unfortunate to see that she actually progressed to cirrhosis. So she actually had a variceal bleed because she already is having decompensated cirrhosis. As you can see by the blue stain, the trichrome stain, there is already nodular formation. And I'm also showing CK7 showing ductal proliferation consistent with her disease. What at that time was for me not super clear is why she was in the early 30s already with decompensated cirrhosis if she had just one mutation on ABCB4. So as now we even know, we have more evidence to see that we should always revisit the genetic testing if the phenotype, if the clinical presentation really doesn't fit what we think that it should be. So in this case, we do reanalysis of genetic testing. So one of the advantages is if you do whole exome sequencing, that will stay the same for the rest of your life, is your germline DNA. So you can go back and revisit that with new clinical information at any time point. I would also like to mention that this is not so different from everything we do in the clinical medicine. Many times we see a patient that progressed in a way that we didn't expect, and we call our liver pathologist. We want to revisit and look again to the liver biopsy. Same happens with radiology. Many times things are overlooked, not really well called, but because we see there is a change in the clinical status, we go back to radiology and review that with hindsight. So with that mindset, I will ask you to look at this genetic testing with me again. And so what we found, there was one mutation that was actually not on the report initially, and is this alanine at the position 934 to a threonine, that was not called because the frequency of this variant was above 1%, so was 1.33% on African Americans, which was the same ethnicity of the patient that we are discussing here. And so by the guidelines, they felt that the frequency was too high to be called for a rare disease. However, with the clinical phenotype that I just described to you, we thought of looking at the entire exome, and we feel that actually this mutation, while a little bit more common than you would expect for a rare disease, is really contributing to this disease. There is also studies from other groups that shows that there is an in vitro functional assay showing a 50% decrease in protein amount and function when you have this alanine to threonine mutation at 934 position. And also when you look in ClinVar is when some of the challenge might arise, because you have labs that call it as a pathogenic, you have the majority of labs call it an unclear significance, and you have even one lab calling it benign. So this really led us to formalize something that we have been doing for years, but without having a concrete meeting, where we put hepatologists, clinical geneticists, and liver pathologists together in a room, and we discussed the cases in a multidisciplinary manner. So this is a clear case where we saw someone that had another variant that the frequency was a little bit on the higher side, and the ClinVar annotation was all over the place if you wanted to look at the pathogenic or the non-significance of benign. And so we felt that we needed actually a multidisciplinary approach to actually say, is this disease causing or not? And we felt that both the liver doctors, the pathologists, and the clinical geneticists, by doing genotype-phenotype correlation, really felt that these patients had biallelic mutations in ABCB4 that were pathogenic, and she has MDR3 deficiency. We really like to bring cases to these discussions of that are of a typical presentation, and that we feel that we need several doctors to actually agree that this is the diagnosis. Again, this is not so different from what many of us are doing in liver tumor board, where we bring cases that are not so clear cut, and we would like radiologists, pathologists, interventional radiologists to discuss and kind of have a multidisciplinary decision about the diagnosis of the patient, which has major implications then on the therapeutic options, the prognosis, and when you bring genetics, also family counseling. Many times, though, I would say that also we don't clearly agree on if this is right or wrong. And so it can feed into some in vitro and in vivo investigations in the lab, which will take longer to bring to the clinic. So where we are now, I think we as adult pathologists have been focusing three genetic diseases: alpha-1 antitrypsin, hemochromatosis, and Wilson disease for many years, and Sanger sequencing was the way to go. The present now, as Verena and myself show you with the illustrative cases, are in the present using next generation sequencing. As I showed you, is very affordable. We are understanding the human genome so much better. So using a combination of gene panels, whole exome sequencing, and whole genome sequencing, depending on what country and practice you are involved, is really the current practice these days. And really the future, which we are already a little bit with a step into that, is really to use these information in providing best care for our patients. And as you will hear from Deepak in the next talk, a lot of new medications that are very efficacious can be good for these patients. So if you actually think about that and make the diagnosis, we actually have treatments that can help them. So really, thinking about genomic analysis for clinical evaluation of unexplained liver disease. You also heard about the atypical cases of DILI. I think that also goes into this bucket. Really the emergence of multidisciplinary hepatology genome rounds, and we are already doing that widely with liver tumor boards. I think the future would be to have these multidisciplinary discussions. Also, I think unifying to get a centralized database of liver-related genes, I think will be very informative, especially as we build more data in what is pathogenic or not pathogenic. Also, considering genomic information when you do clinical trials, because we know that some patients actually might respond better versus others. And also because, as I mentioned, we already have emergent medications that are working really well for genetic liver diseases. And I really expect genetic medicines for liver disease, both rare and common, to be into the market soon. So I would like to finish by saying, while PFIC has historically been actually discovered and diagnosed mainly in pediatric age, advances in genomic medicine and understanding of the human genome have been allowing for PFIC in other monogenetic liver disorders to be identified in adults. So we have to think about them, search for them, and I promise you will find them in a good number of cases. Understand the data to support the cause of your patient's cholestatic liver disease. And if you actually don't get a satisfactory answer, instead of pushing them into a bucket of PSC, PBC, just think about genetics. And also, I didn't have time to go into the detail, but there is a lot of emergent data on genotype-phenotype correlation, ABCB4 related disease, as was alluded somehow in my talk and Verena's talk, can present as just gallstones at intrahepatic cholestasis of pregnancy, or really can progress to cirrhosis and also develop cancer. So that's something that we are, the field is evolving. And actually the EASL practice guidance for genetic cholestatic liver disease is a really good information for practice and what should be done in these cases. Again, timely diagnosis can ensure proper treatment and monitoring. So that's the main reason why we are calling your attention for this topic. Thank you so much.
Thank you, Silvia, also for this case. I know you published it, but I always like it because this going back and then the not calling the variant because it's above 1% in the population, I think makes this so informative. What do you think, Deepak?
Yeah, I think the concept of a genomes round, Silvia, is so exciting, where you can bring all the key members of the multidisciplinary team who are interested, and you can discuss what previous data you have in terms of their genetic testing, and then you can go back and retest. And you said you can also apply in vivo, in vitro sort of testing, which may take longer. But I want to know, how do you get your colleagues, your how do you get people interested in this? Because we're the converted. We're excited when somebody says we tested the genetics, okay? But how did you begin? How did you get your colleagues to engage with you on this?
I think was with some cases of success of them seeing that they couldn't understand, and then all of a sudden, just with the genetic testing, everything started making sense. And I have to give a shout out to at least one of the liver pathologists here in the institution that I work at. He loves these cases. He gets as excited as me when we go from not understanding to, oh, this is so simple, now everything makes sense. So I think he, on the liver pathologist, was really kind of really a force. I also would say that pathologists in general are more okay with the unknown than usually the clinicians. So I think convince them and bringing them on board, it's not as difficult, I would say. I'm not saying it's easy, but it's not super difficult. The other thing that I'm seeing on pathology here is now they are doing the same we are doing in the clinical world of going back to the patient and trying to see things that we didn't see at first. They are doing the same exercise. I'm working with them where they are going back to all the biopsies and seeing, is there something here that I should have seen that now I can see? So they really are doing that on the pathology arena. The clinical geneticists, I have to say, I think the way that I convince them, and they are working really well with us, is that they are start recognizing that their reports are they're not really understood by the clinicians. We are all MDs, but it almost seems that we are speaking a different language. So they felt this as an opportunity to see how can we improve our reports, or can we include now a little summary we can digest what we did very extensively, but in a way that the clinicians actually understand what I'm trying to transmit. So yeah, it has been, I think, a lot of learning to all the parts involved, which is also fun.
Yeah, I think so. And what I also think is that we on our clinician side, we should also, contribute more to elucidating those variants of unknown significant. Because, for example, Deepak, you do a lot of ERCs. I get out stones. We should actually just store this bile and then, analyze it for the phospholipids. If they are low, in a patient like yours, it would be clear that the diagnosis is supported. So take the serum, look at the bile acids. If you do an ERC, take the bile, store it. Even if you don't look at it at this time, you can do it at a later time point or send it to someone, because it's all, for me, it's all kind of like a puzzle, and this is what you do with your boards. It needs to come together to say, yeah, we really believe that this genetic, picture fits to the clinical phenotype, and I'm not overlooking something. And I think what we also should do, like as you said, the tumor boards, revisit the patients. Not you say, okay, we think we found a diagnosis, and then you go and have your life, but to follow up, see what happens, see if this really fits, or if we need to dig deeper, because as Silvia also alluded, I think there's even more genes out there.
Yes, and actually, this is a relatively old case, I would say. So I think now when I look at the EASL guidelines that you were involved in developing, it really fits well. Is if you find someone with even one mutation in ABCB4, you should not say, oh, I don't see you again, or even if the labs are okay for a year or two, you should still see them regularly, at least once a year or once every other year if all the labs are okay. But they should definitely be followed by an hepatologist, because we are still learning which are the ones that actually progress versus the ones that do not progress. I think that is something I would like to highlight for clinical practice.
Yeah, and I can tell you it was really difficult because, as you know, we put in times of what we suggest for surveillance, but we're missing prospective data to validate, do we really make the life better? Do we detect things earlier? If we go with this interval, we don't want to make people sicker than they actually are, but we don't want to overlook. And so my call would be for follow up your patients, put them together, publish them, put them in registries, so that we know what's happening, and the next recommendation can be even more based on data and less on expert opinion.
Yeah, I agree. I think prospective registries where we understand the natural history with follow-up, FibroScan, ultrasound, serum bile acids, and just describing that natural history is where we'll be able to then say to our patients in 5, 10 years' time, maybe this is a high risk phenotype, genotype, and this is a low risk. But we'll only do that with prospective sort of registries, I think.
And I think I want to highlight there was a nice poster on ABCB4 disease, also at AASLD, summarizing, I think, over 40 patients in the adult cohort, a lot of LPAC, a lot of unexplained liver disease, very nicely fitting Sylvia's case. I think they didn't really ask for ICP, unfortunately, but your patient had it in each of her pregnancies, right?
Correct. Yes, that's, yeah. The second pregnancy was even more than ICP. It came to, and she's unfortunately now, she has decompensated cirrhosis with 2 young children, so she is being evaluated for transplant. So that's something that's, I think is a good segue for the next talk of like treatments, because if we actually now we have all the tools to diagnose these patients early and really have an impact in these cases, perhaps to not progress so quickly.